Welcome, everyone. My name is Victor Lee. I'll be moderating today's conversation about, are you getting value from your value sets? A couple of housekeeping items initially. I just wanted to say there's going to be a popular question, can I access a recording? And the answer is yes. We'll make a recording available. We'll send you a link. All of you who have registered, we have your contact information, so you get a link to the recording. Feel free to use the chat in the GoToWebinar control panel. You can chat amongst yourselves. If you have a question for one of the presenters, you can enter that in the chat. I'll try to monitor both the questions and the chat during the presentation, and our presenters are actually willing to take questions as they come. So if you have a question, go ahead and pop it in there. If we're running kind of late in our schedule, I might defer until the end, but if there's a timely question, we're happy to take that. So Erika, why don't you go ahead and share the slides, and we can get started. So again, thank you everyone for joining. We're going to have a wonderful conversation today around how to get value from your value sets. And first of all, introductions. My name is Victor Lee. I am VP of Clinical Informatics at Clinical Architecture. I'm a physician by training, and I'll be moderating today's discussion. I wanted to introduce Erika Ganley. She is a pharmacist by training, and I've had the pleasure of working with her for about over 6 years at Clinical Architecture, working on a variety of data quality solutions. She, up until recently, was on my content development team as a senior clinical content analyst. She also just recently transitioned to our client services department as a client success manager. So hope you have an opportunity to interface with Erika. She's got a wealth of knowledge and a lot of practical advice to share today. I also want to introduce Raymonde Uy. Raymonde is a physician informaticist at the National Association of Community Health Centers, also known as NACHC. He is a health IT expert. He focuses on clinical data quality. He's got a wealth of knowledge related to normalization, clinical data, terminology standards. He's a serial presenter. He knows a lot about health IT and data quality, so we're very much looking forward to hearing his insights as well. And I wanted to also talk just a little bit about clinical architecture. We are a company that focuses on data quality solutions. We live in a health IT world where we are rich in data, but sometimes poor in insights, and sometimes we have trouble sharing information in an interoperable manner. And so clinical architecture provides a suite of software as well as services and content offerings to help you solve some of your most complex data quality challenges. And with that, I'm going to turn it over to Ray to talk a little bit about NACHC.
Thanks so much, Victor. And hello, everyone. My name is Raymonde Uy. You can call me Ray. I'm with NACHC, or National Association of Community Health Centers. We've been around for more than 50 years. We serve community health centers in the United States. If you don't know what a community health center is, a community health center serves 1 in every 4 Americans. And it basically serves the underserved and minority populations who are uninsured, on Medicare, on Medicaid, generally folks who just need access to healthcare. And these are especially crucial in rural communities where there's only 1 doctor or no doctor at all. We have a lot of public health grants getting data from these organizations. So that's us in NACHC. Thanks so much.
All right, so on the agenda for today, we will be talking about just briefly what value sets are, an overview of them, the use cases, some of the use cases for value sets. There are several, so we'll talk about a sample of those. We'll talk about the 6 C's framework that you probably saw in the invitation to this related to value set quality, how to assess that. We'll talk a bit about the medical solution, give you an overview of what we offer here at Clinical Architecture. Ray will speak to the NACHC value sets that they've created and how they've leveraged Somatical in doing so. And then we will end with reviewing the value sets that we create here at Clinical Architecture, also referred to as elements. And so we'll talk a bit about the elements at Foundation here at Clinical Architecture. So without further ado, let's get started. So value sets, what are they? So most of you probably already know what value sets are, but if you don't, so a value set is a collection of codes and corresponding terms from standard clinical vocabularies like SNOMED CT, ICD-10, RX norm is a great example for medications, and NDCs there's also an example. And those terms are used to categorize or group or organize information. And so there are two types here. We're looking at them. So on the left-hand side here, you can see an example of a roll-up. And so with this example, we've chosen heart failure. And in a value set, what you would see is the code system, the code, and the term description. And so what we see here in this list are term descriptions, right? And when we think about heart failure, we know that there are several different types of heart failure. There are also different classifications of heart failure. And so those all roll up to heart failure. So that's an example of a roll up. On the flip side, there's also another type. It's called a lookup list or an answer list. So an example of those would be something that's used to populate a drop-down list. Administrative gender is a great concept for that. And so someone could pick from these options, right? And those are all coded, standardized options. Value sets, you may also hear them referred to as code sets, code groups, or elements. All right, so let's talk about use cases a bit. So when we think about coded terms, right, those coded terms are a way for us to standardize information and for us to be able to share it so that it's understood across the board, regardless of where it came from and regardless of where it's landing, right? And so if we think about some of the use cases for research and analytics, right, you can think about aggregating data for maybe a population to assess things like clinical outcomes, service utilization, cost utilization, right? Anything that can be coded and standardized, you can use in a value set to create analytics around. In looking at patient cohorts, we can take a look at, again, populations of patients who may be receiving certain therapeutic interventions or treatments, or maybe certain at-risk patients who would benefit from further intervention, right? So it's a great way to be able to identify those patient cohorts. They're also useful for things like care coordination. All right, and so related to claims and reimbursement. So value sets can also play a crucial role by enhancing the accuracy, efficiency, and consistency of the data that's used in various stages of the claims lifecycle. So with pre-validation, if you think about how when you go to see the doctor, right, and they take care of you, you go and you go to your visit, and then what they do is they code that visit with a certain code, right? And that's submitted typically to insurance. And depending upon whether or not that code is valid, that claim may or may not be paid for, right? It may be rejected. And so pre-validation is a great use case because you can essentially define a value set of codes that would be covered under a specific plan, right? And you can pre-validate that that code is going to be paid for. It reduces a lot of back and forth and the potential for claim denials because of coding errors. Value sets are also useful for things like adjudication and automating some of those processes, and they're also used frequently as it relates to things like reimbursement in the value-based care models. On the public health side, so when we think about concepts like disease surveillance or detecting notifiable conditions, when I think of notifiable conditions, I think of things like measles, Zika virus, HIV, certain STIs, right? We need value sets to be able to assess things like electronic lab reporting, electronic case reporting, right? And in doing some of that epidemiologic data analysis, it's important to have coded, standardized data that you can run a value set against, right? So that you can take a look at holistically, where is infection spreading? How can we further mitigate that, right, amongst populations? We at Clinical Architecture have recently partnered with a company called Datapult for creating logic around electronic laboratory reporting. So when we think about how a lab result is reported, it's typically reported alongside a LOINC code, right? And so as you create logic to identify whether or not a lab message is reportable or not reportable, positive or not positive, right? You need value sets to be able to determine what's the lab test and what's the code for their result, right? And so that's an initiative that we're really proud of here at Clinical Architecture. Clinical decision support is another great use case. And so as we look at this example, thinking about things like digoxin levels, right? Those serum dig levels, it would be much easier to create your logic for this particular alert using a value set, and instead of having to bring in every single code that's possible for a serum dig level, right? Value sets would also apply to the digoxin medications and the different dosages of those. All right, so moving on, let's chat a bit about quality. So why does quality matter? I think we all know this. Obviously, there are clinical implications, right, to value set quality. If you want your clinical decision support alerts to be relevant, to be correct, we need accurate value sets. We need quality value sets to build that logic, right? Otherwise, it may lead to things like alerts that are inappropriate or potentially misdiagnoses. So that's definitely something to keep in mind as we create and maintain value sets. There are obviously financial implications, right? So when we think about things like claims and reimbursement, the back and forth sometimes that can happen there in that process. If we have quality value sets from the start, that can really help us optimize things like reimbursement. And also, related to risk assessment and workflow efficiency overall, having a quality value set is crucial to those things. Okay, so here at Clinical Architecture, we have developed something called the 6 C's framework. And when we are crafting a new value set or we are assessing the quality of an existing value set, these are the things that we think about. And so we're going to go through these in detail in the following slides. But essentially, you can read them here, but I will read them as well. So it's completeness. Is the value set correct or accurate? Is it current? Is it clear? Is there clarity around the scope? Is it congruent with standards or recommendations? And is it consistent? All right, so just a brief disclosure here. So what we are looking at is an example from the Value Set Authority Center, or the VSAC, as it's often referred to. And VSAC is a repository that is hosted and maintained by the National Library of Medicine. It is a source of truth for the CMS clinical quality measures. And aside from that, there are also several value sets available here from several different stewards, right? And so these examples that we have pulled, we are not going to be showing the steward. We understand the work that goes into creating and maintaining value sets, but I feel like these are really great examples to be able to review and to highlight how there can be certain quality issues that we need to be aware of and how we can rectify those, right? And so the first C that we are going to talk about today is completeness. And so with completeness, what we're really looking for are errors of omission. Are there terms that are missing, right, that should be here. And so with this particular example, this is a value set for ARBs, or angiotensin II receptor blockers. These are medications that are used for hypertension, and they're also used for heart failure and a variety of other off-label use cases. But what we see here is that there were concepts missing in this value set for these three ARBs or ARBs, right? And what's interesting is that we can see right at the top here, there are brand name concepts for candesartan, but there are missing generic concepts for candesartan. That drug has been out for quite a few years now. Most patients are not taking the brand, they're taking the generic, right? It's a lot more cost effective. And so it's important that when we create value sets, especially for drug classes, that if it's not all encompassing of, both single and multi-ingredient, or if it doesn't include every single medication that's part of that drug class, it's important to note that in the scope. That was not noted here. And so it does appear that these terms are missing, right? So something to be aware of. Second C is correctness. So are there errors of commission, right? Are there additional terms here that are not relevant to include? So with this example, it's a value set that's intended to represent oral antibiotics. And so if we look a little closer, we can see that there are ophthalmic preparations here, and there are also topical antibiotics here. And so, for example, if you were using this value set to create logic for, let's say, a clinical decision support alert, right? And maybe it's for drug interactions. Likely, you're not going to need topical or ophthalmic preparations, right? Because the pharmacokinetics are very different for those medications. And so it's not appropriate for them to be in a value set for oral or PO antibiotics. Currency. So when you're looking at either using a value set or, as we maintain them, we need to think about, when was this last updated? When was it reviewed, right? And so we can see here, just from this screenshot, the definition version is from 2016. That was over 8 years ago, right? And if we think about the concepts and the terms that are in this value set, so we've got terms in here from ICD-10-CM and SNOMED-CT. Think about how many updates have taken place to ICD-10 and to SNOMED since 2016. I would question whether or not this value set contains everything it needs to, for one, and also it's very possible that there could be terms in here that have either been retired, been made obsolete, been replaced with other concepts. And so this is important that we look at this information. Clarity. So is there a well-defined scope? Are we accurately and inclusively defining what is here in this value set and what's not, right? So with this example, we can see that the clinical focus is diabetes, and there's a data element scope of diagnosis, right? But what it doesn't tell us is, are there concepts for type 1 diabetes here? Concepts for type 2 diabetes? What about gestational diabetes? What about diabetes insipidus, right? Pathophysiology is completely different for that. And so it's important to note exactly what's included and what's not. Congruence. So are your terminology bindings in line with expectations, right? Are they in line with the standards set forth by the United States Core Data for Interoperability, for example, or USDDI? And so with this particular value set, we're looking at an example of UMLS codes for COPD, or chronic obstructive pulmonary diseases, right? Something to keep in mind is really about how you need to know your data, right? And so if your use case is to, exchange information from one site to another, right? USCDI recommendations are SNOMED CT and ICD-10 CM for conditions. And so this may not be the most appropriate value set for your particular use case, right? Consistency. Does the steward apply a uniform approach to authoring and maintenance of a value set? So as you're looking at value sets from the same steward, does it look like 15 different people authored those value sets, or does it look like one person authored those value sets, right? Is there a consistent approach to things like naming, right? Are there specific naming conventions that you see, and are they consistent from one value set to another? How about, you know, certain domains, right? So do the value sets for medications, are all of those developed and maintained a specific way versus conditions, right? And is that information available and transparent, right? That's important. All right, so there are challenges, right, with optimizing value set quality. You may be wondering, why on earth am I showing you a picture of a dog, right? So stay with me, I promise there is a point to this. So value sets are a lot like dogs or cats or children in that they require attention, maintenance, and sometimes a little TLC, right? So if we take Dave here, this guy was a birthday present for our daughter. He's now 5 years old, but we didn't just expect to pick him up and do all the things that one would expect of a dog right off the bat, right? We had to invest time in teaching him things like how to walk on a leash, how to not go to the bathroom in the house, right? We take him to the vet every month for injections and every year for vaccines, right? We have to take care of him. Value sets are very much the same in that, you know, when we think about medicine is ever evolving, right? If we just think about things like NDC codes, for example, think about how often those change, how often they become obsolete, how often new ones come out, how often new medications come to the market, right? Not even just new medications, but also new classes of medications. And so we have to be able to keep up with that as we maintain and develop value sets, right? Other non-dog related challenges to optimizing the 6 C's or optimizing value set quality are things like resource constraints. And so you may not have the people to be able to develop these, to maintain them, right? Things like maintenance challenges. So when we think about how SNOMED CT, ICD-10, all of the standards, right? RX norm updates every single week. Are people able to keep up with that? Keep up with those changes? It all depends on whether or not you have the resources, right? Or also the tools, and we'll talk about that in a little more detail later. But essentially, if you are maintaining a value set in a spreadsheet and you have to review the release notes of what comes out with every release of a standard terminology, that takes a lot of time, and that's a challenge, right? And so we've developed some tools here at Clinical Architecture that have really made that seamless, but it is very much a real challenge outside of, you know, using Somatical. Things like process inefficiencies and governance and management challenges, right? And so we've heard from different clients and from other organizations that sometimes someone may have several different teams creating value sets for the same purpose or for the same reason, but there is no governance or established editorial policy around how those value sets are created and right. So it looks like you've got 15 different people creating value sets because you do, right? And that can lead to just some variation that is not effective in using them. All right, so switching gears a bit, we're going to talk about what we offer here at Clinical Architecture, and we're going to talk about the Somedical solution. So we offer essentially a triad, right? And so today we are focused on content specifically, but if you are resource constrained and you don't have the people to be able to build and maintain things like value sets, we also offer professional services, and we have a fantastic team of clinicians and informaticists that can develop those things for you. We also have software that is fit for purpose. And, you know, it essentially makes creating value sets just a lot faster, and keeping up with those maintenance challenges, it makes a huge difference. It's much, much different than developing them in spreadsheets, I will tell you that. All right, so in Somedical, we make content available to our clients via something called the subscription portal. And we can see here in the middle, this is proprietary content that we offer from Clinical Architecture. Element Set Foundation is our offering for value sets. We'll talk about that a little later. But in addition to that, we have things like terminology standards, right, that you can pull down directly from one source of truth, and other common data sets. And the benefit to getting your content from this subscription portal is that we have an entire team of content engineers that are dedicated to making sure that the structure of that content that comes in and the structure of the data is of sound quality, and that is a huge benefit. Again, this is just a sample, right? So we have over 450 packages of content. I am sure that if you have questions about what we have, we'd be happy to answer that. It's likely that we do have the content that you need. All right, so I will turn it over to Raymonde to talk a bit about the NACHC value sets.
Thanks so much, Erika, for that really great overview of value sets, the 6C frameworks, because definitely we see this a lot in the work that we do, especially with the grant work and population and public health projects that we have at NACHC. So, okay, here goes. I'm backing up a little bit here. What you're seeing right now is generally our workflow of how we receive data, how we map them, what we use the mapping tools and the value sets for, or the element sets in Somedical. On the left-hand side, you will see what's called local terminology or source catalogs. This is basically the data that we receive from our partners, our data partners. And in this case, these are community health center networks. So community health center networks are organizations that have a group of health centers under their wing. They're usually under the same electronic health record vendor, Epic, Athena, you name it, eClinicalWorks, NextGen. And they all send their data through us, again, by SFTP, through any encrypted method. Once we receive that data from them, it's usually encounter data, medication data, observation data, you know it. And before they send these to us, we give them a list of data elements that is pertinent to the project. For example, if it was a project on hypertension, we would need value sets that are related to the diagnosis, for example, of hypertension or medications used for hypertension. So we give them the value sets. We use the value sets, again, for example, from CA elements or from what we've created ourselves. And then they would query their EHR database for that information. But even if you give them all of the codes and all of the things that you want, what you end up receiving is a table without codes or incomplete codes, or the quality of the codes is not there, wrong codes, doesn't use standard terminologies, use proprietary coding system internal to the EHR, for example, or free text. We would then map it to our reference terminologies, right? SNOMED, CT, ICD, you name it. And then we would use, once we normalize the data, then we were able to assign the different encounters, assign the different unique patients to each value set or element set cohort, so that in this case, we can identify who in fact are the patients that are taking a specific class of antihypertensives, for example, diuretics. right? And assuming, and of course the C elements, I double check that also. If you use those, you will 100% know that all of the people or of the patients in this cohort are all the ones prescribed or are taking diuretics and diuretics only, and not beta blockers, not ARBs, not ACE inhibitors, diuretics. So I have a lot of examples on that. So I'm going to backtrack here and talk about one other project that we do. It is about reproductive health, privacy, and security. The whole point, so this is a federal rule from the Office of Civil Rights. There are also two state bills, one from Maryland and one from California. And you're seeing that there, the Assembly Bill and House Bill. The key points in these, because you don't have time to read it, it prohibits the use or disclosure of personal health information that are related to reproductive health. Number two, they cannot disclose or release data related to this kind of information without patient authorization or consent. And number three is the requirement to segregate different data in the EHR related to reproductive health and protect them. In the bottom, you're seeing compliance dates, and you can see that we're already past the compliance dates. So this is already legal implications in effect right now. So lots of health IT vendors are trying their best to figure out how to comply and how to protect this data. The issue here is really, again, segmenting the data, identifying which reproductive health information need to be segmented. And that's what the work that we did, how this relates to the work that we do. So on the left-hand side, you're seeing the different data elements in this case: abortion-related services, gender-affirming care, contraception, infertility, miscarriage management, prenatal care, and which statute each of these concepts apply to. Again, on the left-hand side, there has to be a way to, again, segment all of the information or all of the patients that have, for example, transgender care or contraceptive care or had intersex surgery, stuff like that in this case. The next, again, protecting that segment of data in your database is crucial, and that was part of the statutes. The second part here is, once that is flagged, how do you get consent from the patients themselves, who, if there's a request to pull their information from the EHR or it gets pushed out, there has to be consent from the patient themselves. Thankfully, there are industry initiatives which are trying to help manage this type of sensitive data in terms of confidentiality and security. There's the Sequoia project and their shift interoperability terminology work groups that is open and welcome for all of you guys to join. This is especially crucial, especially with what just happened with CrowdStrike. Just putting this into perspective, everybody knows that data problems or threats to data security costs healthcare organizations a lot of money. And you're seeing here, again, based on the rulings, the diagnoses are use ICD, SNOMED CT, procedures use, again, CPT, HCPCS. We even put ICD-10 PCS there and SNOMED CT procedures. Not really, I don't see that a lot, but again, we have to make sure we have everything ready when we are protecting information like this. Medications, again, are all in RX norm. While I know inventory systems use NDC codes to track which warehouse or which factory produced the drug, again, in USCDI and the recent rulings, it has to be on RX norm. So you have to have a way to relate NDC codes or any other medication codes to RX norm. And last but not least, LOINC, right? LOINC, again, it's not just for labs, it's for observations and any type of other observation documentation. So you have to have value sets to encompass these concepts on LOINC. Again, LOINC questions or LOINC answers. And what you're seeing here on the screen think about these as different value sets or different element sets. You can group abortion medications, for example, having different value sets for methotrexate injections. There are different formulations and different preparations of methotrexate, but in this case, only the injection is used for abortion medication. Similarly, for mifepristone and misoprostol. So creating all of these value sets, you really need to have a good handle of the clinical practice guidelines from each different specialty or subspecialty society, and have an understanding of all of the different fundamental elements that really encompass what you're trying to represent. In this case, another example would be abortion. You can cut and slice and dice abortion in different ways in this case. Is it trimestral? Is it first, second, or third? There are codes for that and different value sets that encapsulate first, second, and third. There are also different codes for groups of codes that represent spontaneous or miscarriages, for failed attempts, for elective abortion or induced abortion, or medical and surgical management. So these are all different value sets that you can create and can roll up and group together so that when you are looking at your data and you're trying to figure out which groups of patients need to be included into what, or which different encounters need to be grouped into where, when you're doing comparative analysis, this is especially crucial because if you don't have a comprehensive, complete, concise, following the 6C framework of value sets, then you will really miss a lot. Either you miss a lot or you overestimate your analysis. So it's the same, apply the same thing to what you're seeing in gender affirming care. Again, you can group all of these things, but again, going down from the child concepts and rolling up to the parent concept, I think is our methodology. And what you're seeing here is something called sematical waypoint. We use this in our projects for the past 4.5 years. What this does is once we receive information or we receive the data from our partners, even if you request NDC codes or RX norm codes, so sometimes their system doesn't report that out. So in this case, we received GPI codes. So GPI codes are medication codes from Wolters Kluwer. It's from a coding group called Medispan, for those who are aware. You're seeing Clemara Pro, Depo-Provera have those GPI codes listed here as source codes in that source code column. The target here on the right-hand side are RX norm concepts. So the target name here are the actual RX norm descriptors, and the target codes here are the RX norm codes in RX norm. So in this way, we can normalize the data that we are receiving from multiple different data sources or different data partners so that we can semantically aggregate them together. Because if you don't adhere to one value set as a gold standard, then you are technically not supposed to be grouping or combining these data sets together and creating analysis like that. It's absolutely wrong. So I'm going to skip this. This is another application of value sets. This is a paper recently published in the Journal of Women's Health. What you are seeing is an algorithm of trying to identify and identify delivery dates or actual delivery records. This is the data cleaning flow chart that we had to do to clean up the data we received from multiple partners. What I want you to look at here is the outcome exclusion section in the middle top portion here. You're seeing molar/ectopic, pregnancy loss, and stillbirths. Those three concepts needed to excluded from our analysis because they just had to be. And you need value sets with those specific codes, all of those codes that related to those, so that you can be certain that you have excluded those in your analysis. Again, that's what the power of value sets here in this case. Inclusions or exclusions, you can use them for both. Here are different prenatal care measures in the EHR, and these are from 2 participating health center controlled networks. What I've highlighted here are the actual measures. For example, postpartum visits within 8 weeks of delivery. You need a value set that contains all of the codes for postpartum visits. What are those? Are these claims? Are these billing codes? So having a value set for that is necessary to find the patients who actually had the postpartum visit. Because again, it's not just one code, it's multiple codes. The same thing with contraceptive counseling and provision. There are different billing codes used for contraceptive counseling. Similarly, for postpartum depression screening, there are multiple questionnaires that different organizations adopted in their EHR. So again, I can be a psychiatrist and I think that this depression screening tool is better than this other one. Is the PHQ-2 or PHQ-9 better than the Edinburgh postnatal depression screening tool? So all of those are on LOINC, and you have to really model all of these screening tools so that you can get at least you can either compare different screening tools or you can aggregate them together and say that all of these patients have had any type of postpartum depression screening. Same with treatment. What are the actual medications used and recommended by the society, the specialty society, that are used for postpartum depression? Because that, again, is very distinct from, again, treatment of major depressive disorder or cyclothymia or minor, those things. Same for screening for gestational hypertension. You should have a value set for, again, gestational hypertension, and a value set for screening of what are being used to screen for gestational hypertension. Is it the oral glucose tolerance test, right? How many grams of glucose should be there, right? Those things. So again, this puts into perspective that all of these different electronic clinical quality measures are all reference a value set. And I think the biggest issue we are encountering is that some of these value sets um, are not being updated as frequently as we want, or it's the possibility of those value sets being incomplete themselves during the creation of that. Another project that we were doing is something called Occupational Data for Health, which is a collection of occupation and industry information from patients. The original idea was to help collect this data to identify essential workers during the COVID pandemic. But again, occupation and occupation industry uses their own standards. Occupation uses what's called SOC codes, or standard occupation codes, classification codes, and industry information, right? What industry are you in? Healthcare industry, pharmaceutical industry. Those also have specific standard codes using what's called NACHC, or the North American Industry Classification System. But we had to use different mappings for which occupation and industries are actually essential, and we used some medical tooling by defining element sets that use the NAICS and SOC codes. In this case, these are from FinVads, different value sets that represent past or present industry, which occupations, and again, these are all based on a standard used by the Bureau of Labor Statistics and the Census Bureau. Similarly, again, employment status also has a value set, and those value sets contain the specific codes necessary to represent those concepts. Are you fully employed? Are you part-time? Are you not in the labor force? Those things. So again, the tooling really helped us identify and group these patients together. Who are the patients that are in the healthcare industry? We need an element set to help identify it. So what you're seeing now is another tooling in Medical that we used, which contains a value set for employment status, a value set for work classification, work schedule, and a value set for occupation SOC codes. Again, the full group and different minor groups or subgroups. For Million Hearts, this is another project where we were so the American Medical Association wanted to look at which antihypertensive classes are being prescribed to patients, and if medication intensification is being properly applied across different races and ethnicities. But to do that, you have to have value sets that separate all of the different antihypertensive classes that are being prescribed. Like in our previous example, a value set for diuretics, a value set for ACE inhibitors, a value set for beta blockers. In this case, we can say, in this project, we can say that this patient is prescribed 2 classes of antihypertensives, 1 diuretic and 1 ACE inhibitor, for example. So you can create those analysis, but you can't really handle the millions of records that we had to parse through if you didn't have complete value sets. In this case, we used the CA elements value sets for antihypertensives. It's pretty updated in my experience, and it helped us do proper reporting to AMA and to CDC. Another one here is cholesterol management. We needed value sets for statins, and there are different statins, different combinations and different formulations. There are even statins combined with antihypertensives. So how do you wrangle all of that data? What you're seeing here in your screen are all the different value sets that we used to be able to perform our data analysis for AMA and for CDC. You can see again combinations of different classes of antihypertensives in one single pill. again, these are the challenges that we faced, and we were able to wrangle that information. Another thing here would be statins. There's high intensity, you're seeing on the right hand side, there are high intensity statins and low intensity statins based on the guidelines. And we had to get the general group statin value set and split it into two, high or low, so that we can do comparative analysis. I'll speed up over here. For HIV clinical decision support, we needed value sets for PEP and PrEP, for pre and post exposure prophylaxis. And these value sets are used to create FHIR applications, because the FHIR applications have to reference a value set to create that decision algorithm, or if you're using CDS hooks or clinical decision support hooks in your EHR, they need those codes to trigger, like what Erika was mentioning earlier, to trigger properly the clinical decision support notification or push or pull notification. Similarly, for opioids, we needed value sets for opioids, and value sets also for the patients diagnosed with substance use, substance abuse. How do we cut and slice and dice our population so that we can do comparative analysis? Another thing here would be we need created value sets also for the different adult immunizations and the schedule, the required schedule required by CDC. This uses CVX codes. And again, we also need value sets because these things update also. Every year you have new codes for flu shots, or in this case, we need new codes also for COVID shots. And this was used again for health centers in this case to do public health reporting, to connect to their state immunization information systems, so that even if you move states or you move cities, your record goes with you. But the only way to do that is to have a value set that identifies those patients and helps them report these to their IIS. I'm in my last few slides. What you're seeing here is a social drivers of health screening tool called Prepare. And this is a good example. This is on LOINC. You see, again, each question here on the questionnaire has a LOINC code, and each of those questions have a LOINC answer. And each of these LOINC codes are represented in a FHIR code, right? That's the one, that's the XML code here you're seeing on the right-hand side. While you can reference individual codes in FHIR, you also need to reference value sets on FHIR. And those value sets have OIDs, or object identifiers, that reference VSAC. So if there are population health tools that you need to do quality measure reporting, you have to reference the FHIR API to call the OID in your code on the appropriate value set necessary. So if the value set is incorrect and the value set is incomplete, inconcise, and just wrong, then your quality measure will not perform or will not report what it needs to perform. And just to wrap things up, see, we know that HTI-1 exists. We know that HTI-1 requires all certified health IT vendors to use USCDI version 3 by January 1st, 2026. And in this case, all of the data elements on USCDI version 3, which we are seeing on the left, a lot of these will need value sets as well. Pregnancy status, for example, what are the codes that indicate pregnancy status? What are the value sets used to identify smoking status or people who are smoking? And in HTI-2, HTI-2, which is the new proposed rule, will now require USCDI version 4. And version 4 on the top right is what you're seeing here. Includes, again, alcohol use, medications instructions, average blood pressure. What is the value set for average blood pressure? Because there are multiple average blood pressure measurements on LOINC. You can't just select one. You have to select a group of codes in a value set to pull that from your database. Again, there's a new baseline of USCDI, and the expiration date, or the date of it comes into effect, is January 1st, 2028, which is a few years from now. But again, supporting all of these data elements on USCDI version 3 and onwards need proper vetted value sets, following the 6C framework and using hopefully a modified Delphi process to make sure it follows the 6C. And that's me. Reach out to me anytime if you have any questions about any of our processes, and I'll be happy to help.
Great. Thank you so much, Ray. And I have seen several questions roll in. That's great. What I'm going to do is hold those for the end. I'm going to let Erika go through the last few slides, and we'll try to get through as many questions as possible after that.
So I'll just quickly wrap up here. And so we're going to chat a bit about what we offer as a value set solution from Clinical Architecture. And Ray did a great job of showing us briefly just a subset of some of those value sets that you all at NACHC used to model some of your content for medications used for hypertension and dyslipidemia. So this is just a select few coverage areas that I've chosen to highlight that we cover in our value set solution. So we cover acute and chronic condition management, things like sepsis, heart failure, diabetes, right? We have different value sets to represent those variations of some of those conditions. As it relates to behavioral health, things like depression, postpartum depression is actually something that Ray mentioned earlier, substance use related disorders, right? As it relates to infectious disease, we've got several value sets for things like notifiable conditions like HIV, and not just for the conditions, right? But also for relevant medications or screenings like Ray mentioned the PHQ-2 or PHQ-9 for depression, right? We've got value sets for those as well. In the oncology space, we've got value sets for both solid and liquid tumors. We separate our value sets based on histopathology, whether that's defined or not. And so that's been received well. And then we also have value sets related to immune-mediated disorders, rheumatology, and also several other surgical specialties. Quick breakdown of what we offer. So we have over 2,500 out-of-the-box value sets that are available for use. Those are updated quarterly. We review those with eagle eyes, and I'll talk a bit about how we do that in the next few slides, but this is just a breakdown of what we offer here. And so when we think about things like updates, right, we are very intentional with a T in how we create our rule-based definitions for value sets. And so by doing this, this sets us up for success as updates come out from these standards, right? And so we leverage things like the hierarchies and the ontological relationships in these standard terminologies. And by doing that, our expansions are automatically calculated, right? When these terminologies change, we can see exactly what's been added and what's been removed. And that's very useful from the perspective of keeping these things up to date and current and accurate, right? It's a much different experience than creating a value set in a spreadsheet and then having to manually comb through release notes to see what's been affected, right? We may or may not catch that if we're developing value sets in a spreadsheet, but with tooling that's developed for the purpose of creating and maintaining value sets, it's a seamless process, and it's one that has had excellent results. So just to recap, we talked about the 6 C's of value set quality, and this is something that we take very seriously when we develop our value sets from Clinical Architecture. And so in the CA Element Set Foundation, again, we've got over 2,500 out of the box value sets that are available for use. Talk to us if you're interested. Something that we also provide are things to our clients like teaching them how to essentially leverage some of the functionality in Somedical to be able to create those intentional value sets and value set definitions in a way that's scalable and that's seamless, right? And so this is something that we always take into consideration when we are developing our content. All right, I'll turn it over to you, Victor.
Great, thank you guys so much. I wanted to say special thanks to Ray for sharing the NACHC experience and some really compelling real world use cases for value sets. Also thank you to Erika for sharing the 6 C's framework that we've created for assessing the quality of value sets. I also want to just make a plug because we're doing a little mini research study on applying the 6 C's framework kind of in a manner similar to what Erika described, but we'll be publishing a white paper in the coming weeks and months, and so stay tuned for that. And also thank you, Erika, for talking about the Clinical Architecture Element Set Foundation. If you guys have challenges with authoring and maintaining value sets, talk to us at Clinical Architecture and explore how we can help, whether it be from a software services or from a content perspective with Element Set Foundation. Now, we only have a couple minutes left, and there are several questions, and I'm going to kind of take them in the order in which they came. If we don't get through all of them, we'll provide written responses and submit them to the audience. But here's the first one. CMS has been very focused on harmonizing value sets, although it helps to reduce the amount of similar value sets within VSAC. My needs based on experts may be different from others. Do you think harmonization is critical, or is it better that multiple value sets exist of the similar or same type? So it's a question around, should we be harmonizing the value sets that are out there? There's some heterogeneity. I don't know if Ray or Erika, if you have a comment on that.
Erika, would you like to go first, or I can go first?
Oh, you can go ahead, Ray.
Yes, happy to tackle this question. Multiple value sets are tricky, and I'm sure the person who asked this question have been on VSAC. There are multiple stewards and multiple value sets submitted there for similar concepts. And generally, how I try to filter them, for example, is to look at the number of codes, and I start with the ones to the largest amount and just go through those. So it really depends on your workflow. I do think there is a huge value in harmonizing this effort. I think that is why Shift Interoperability Work Group exists, is it tries to harmonize and do a modified Delphi process so that different experts can come in and say, you know what, this code, we don't really use this in practice. Oh, you know that code, well, it makes sense. It really doesn't fit the intent of the value set. I think the problem is that there are no standard operating procedures that have been set in place. So it's been a wild, wild west putting your value set on VSAC. And it's difficult to get subject matter experts to also weigh in and tell you what code is missing and what's not. Again, providers were not trained to be coders and billers. I don't know why I'm doing this work, but we're doing informatics, and it's a much needed thing, I believe. But if you try to get SMEs, there's only few and far between people who are actually interested and have actually gone through training in ontologies and terminologies and what all of these means. I think that's a big hindrance from the CMS side. Thankfully, we have, again, NCQA and NCQF trying to validate all of these measures. Unfortunately, again, people are left to follow the regulations, for example, for which value sets or OIDs are used when computing the quality measurements, numerator and denominator. So yes, there is a need for that, and I haven't seen the best solution for it yet. But at least the tooling is there to actually help help people chime in. So I think, Erika, can you tell them about Semedical's method of doing the Delphi process? Or
Great,
they
thank
can
you for
comment.
that, Ray.
Yeah, they can comment on element sets. Go ahead. Sorry.
Yeah, and I think we have less than a minute left, and we have a few more questions, and like I said, I will make sure that we distribute written answers to those questions. I apologize for running out of time, but again, I wanted to thank our presenters. Again, there will be a recording that we'll make available, and I hope this has been informative and beneficial to you in terms of learning about how you can get value from your value sets. Thank you for your participation, and again, let us know if we can help. Thank you so much, everyone. Have a great day.